So let's put this person. This is a hypothetical person, hypothetical lady. So um, just to make the context correct, this is Lena, who is obese, who doesn't have diabetes. She has tried to lose weight multiple times, as your and mine experience in the clinical practice will be there. Very worried, both you and your person, your patient, and certainly this takes on emotional, physical burden and activity excess weight in the daily life. We have heard all this thing. Now, why is Lena struggling to lose weight? And this we have gone through. So I don't want to go in the details. We are talking about intestine, adipose tissue, pancreas, stomach, and we are talking about variety of hormones. Nicely, Dr. Nigam told about hunger hormone and satiety hormone. Our concentration will be on GLP-1 and the GIP. That's what we are here together to talk. And our organ of interest, brain, adipose tissue, pancreas, and stomach. The most important part of this slide, I want you to get your attention, is on the adipose tissue. You see the GLP-1 activity, Saptarshi has nicely told about the different organs, but in the fatty tissue, the GLP-1 has reasonably no role. So we are all talking about GIP activity, increased insulin sensitivity, increasing lipid buffering capacity, and increase the storage capacity. And that brings the discussion of this date of the molecule, which is marketed as Manjaro. I will be using both Manjaro and tirzepatide together. It is the first in class, once in a week, and dual co-agonist. It's a GIP receptor agonist and GLP-1 receptor agonist. Half-life is around 5 days, which makes it used once in a week. And we do not need any dose adjustment for this molecule, and activates both the receptors. We have seen the cartoon, reduces craving, increases feeling satiety, decreases hunger, and lowers body fat mass, including visceral fat. Now, this is what now the Sarman program that I am going to discuss. Anybody knows the meaning of the word, English meaning of the word surmount? Yes, sir. To deal successfully. Excellent. Thank you. Yes, very right. It means actually deal successfully with a difficult problem. And we understand obesity is a difficult problem. So this surmount is not like S stands for something, U stands for something, R stands for something. It is not like an UKPDS, United Kingdom Prospective Diabetes Studies. It means we are dealing successfully, and actually it dealt successfully. No doubt about that. That's what I'm going to tell you. This is the clinical development program. This is a standard way of any molecule now in the market has gone through. We have published report of Surmount 1 to Surmount 4. Surmount 5 also we have the top line result, but is not yet published. So I am going to talk on Surmount 1 and 4. There is a particular reason why 1 and 4 is clubbed together. In Surmount 1, we have compared with injectable placebo, which I am going to tell you that people with obesity or overweight for 72 weeks. And in Surmount 4, we after stopping, what happens, how much regain, and what happens if we continue. That's all the purpose of this. And the Surmount 4 has 88 weeks. Let's start with the Surmount 1. Now, this is the plan. We have a run-in period after the screening. Then we randomized into 1 in the 4 group. In randomization ratio is 1 is to 1 is to 1 is to 1. So this is one group which is injectable placebo. The pen exactly will look like tirzepatide. So neither the patient or the subject and the investigator will know. So this is a double blind randomized clinical trial. That's the randomization. The second arm will give 2.5 milligram once a week for 1 month. After that, increased to 5 milligram and continued throughout the study period. Third group, 2.5 milligram per week once a month, 5 milligram once a week 1 month, 7.5 milligram 1 month, then increased to 10 milligram and continued till the end of the study. And the fourth group, we have done exactly same, We have gone to the full dose, that is 15 milligrams subcutaneous once in a week, and continued till the study. Now, this is very, very important whenever we are talking about the adverse event. You will see the difference between group 2, group 3, and group 4, particularly because the dose is getting increased. So, this is the primary endpoint. We wanted to see the weight, that's what the study for at the 72 weeks. And also, we want to see how many percentage of the people lose 5%. And there are secondary endpoints, I'll tell you in the result time. And important to remember that indications of people. Now, in Surmount 1, we have not included anybody with diabetes. So, cutoff HbA1c criteria was 6.4. Anybody more than 6.4 has been excluded. They have BMI more than 30, or if it is BMI more than 17, it's one of the four, at least one of the four weight related complication. And these four are hypertension, dyslipidemia, cerebrovascular or cardiovascular, atherosclerotic cardiovascular disease, and also obstructive sleep apnea syndrome. At least one of these four. Okay, let's start with the weight reduction. Saptarshi has stolen my this slide. So if in the placebo arm, the group 1, the 72 weeks we are losing this. Group 2, 5 milligram, this much. And group 3 and group 4, so 10 milligram and 15 milligram, I'm sure this will generate some question. We are losing around 21 to 22%. So 21 to 22%, you remember, easiest way for me to remember that if somebody we are starting 100 kg, we are coming to 78 kg. Or at least 78 kg, more than that in average. This is important. This is an average, whole of the group. And we have recruited in this more than 2,500 people. If you see in the bar diagram, in kg, you can see just 50 kilogram, placebo this much. The placebo arm has received exactly same standard of care. That means reduced calorie plus physical exercise. With the 5 milligram group, 10 milligram group, and 15 milligram group, we are losing 22 to 23.6 kg of weight. 72 weeks, you'll remember the trial duration. Now, if you see one of these, very nice way to show is that how many of our people lost more than 25% weight. That means suppose you start with 100 kg, how many has reached to less than 75 kg. So more than 25% weight loss. And if you are getting 15 milligram, that is the group 4, 2 out of 5 actually lost more than 25% weight. And again here 1 in 3, 10 milligram group. If you take more than 20% weight loss, if you cut down your target, then automatically you will see more people reaching the target. Nothing, no molecule has shown this much benefit. And that's what the success of the Surmount trial. Okay, 4 in 10 receiving 15 milligram weight lost more than 25%. Now again, this is again Saptarshi told, whenever somebody losing weight, you want to see what you are losing. We are definitely losing a little lean body mass. That will inevitable with any weight loss program, but most of the weight loss is the fat and the visceral fat. And also, very interestingly, we all the time talking about measuring obesity. We don't talk about much how the success comes. Waist circumference in the Surmount program, in Surmount 1 trial, in 72 weeks, look at the loss of waist circumference, 20 centimeter. Humongous approach. Nothing in the world, no pharmacotherapy has done this before. Along with this, we have some secondary parameters, secondary outcome parameter. All of them are beneficial direction, loss of systolic BP, drop of diastolic BP, drop of triglyceride, rising HDL, decrease LDL. But just one point I wanted to highlight, whenever EMPA come with empagliflozin, and we saw the diabetes molecule reduces a little bit of blood pressure, we are so excited. But in empagliflozin or any other gliflozin, the weight loss is, BP loss is around systolic 2 average, diastolic 1.5. And here you see the benefit of it. Systolic blood pressure loss 7 to 8.2 and diastolic is 4. So this will have a huge benefit on our clinical outcome. Okay. Now, next question is that everybody loses weight? Very, very important question. What happens to everybody? Now, we all the time talking about percentage and average. Now, this is one of the nice statistics which recently has come for a decade or so to show. So I'll just try to hide, all of them are same. I'll just discuss on this one. So all of them will be easy. This is my 15 milligram group. This is my group 4. So they start with the 2.5 every month. We increase to 5, 7.5, 10, 12.5, and 15. You see here, you can see how much is that? More than 40. More than 40% of weight loss is the extreme. So in general, nearly 98% weight lost. But this is a subgroup which is around 2%, which actually did not lose weight. Now, we don't have any very much a serious interest of me to the Lilly medical team to give us a bit more data so that for our understanding of treating obesity increases, that we know that why some people do not increase. But obviously, any molecules, 98% people losing weight is wonderful, and see the extreme of that is more than 45%. Okay. Proven efficacy at every dose. So our primary outcome was that, you remember, one of the target more than 5% weight loss. We have seen more than 96% people, whether 10 or 15 milligram lost more than 5% kg. Obviously, this is nothing. So it's a very, very successful trial. So our hypothetical lady, the Lena, so if Lena takes Monjaro today with a reduced calorie diet and increased physical activity, she can attain weight loss in 4 weeks, can see significant sustained weight loss and experience improvement in the cardiometabolic profile. Now, next question comes about safety. I'll go very quickly. Here we are seeing in the rightmost is the placebo, and this is group 2, group 3, group 4, 5, 10, and 15 milligram. As expected, most common adverse event is the gastrointestinal effect, which is placebo around 7, 8, 9%, here around 20 to 30%. And you see that as the dose increases, all this increases. That is fine. Important to see that other parameters like an abdominal pain, hair loss, dizziness, nothing much difference is there, including pancreatic any side effect. No effect of pancreatitis at all. Major adverse cardiac event and the SURPASS trial, the offline data that Saptoshi has told, this is not a very concern. So more or less, other than expected upper GI symptom, nothing much we have found any alarming to worry about. How many of them discontinued? Any trial, it is very, very important because of adverse event in the placebo, 2.6%, but here around 4 to 6%. So that's very, very important of any trial. That we know any molecule when you try this group, and this is the situation that some people withdraw it. Now, what happens to nausea? With the placebo, also people see nausea, but that get better. And again, with 5 milligram, 10 milligram, 15 milligram, you remember when I started about escalation, as you see that with the 15 milligram, obviously it was a bit more and it continued a bit of a longer time. But the fact remains, most of the people completed the trial, and we have the data of all of them, and most of the people nicely tolerated the similar data about the vomiting and the diarrhea. So in the SURMOUNT trial, what we essentially take home is that if you use this 72 weeks, BMI more than 30 or BMI more than 27 plus one weight-related complication, as I told, hypertension, dyslipidemia, cardiovascular disease, and obstructive sleep apnea, 5, 10, 15 milligram for more than 5% weight loss. 15 milligram has around 22.5% weight loss. And this is the percentage you have explained to it. Improvement in blood pressure, waist circumference, lipid level, and most common adverse effect is the gastrointestinal side effect, but obviously which is quite a bit accepted. Quickly, I'll go to the SURMOUNT 4, and very important in our clinical practice is that when we stop something, it again rebounds. So what happens if we stop and don't stop and continue? So in the SURMOUNT 4, again, same inclusion exclusion criteria. Screening period, we start with the 2.5, 5, 7.5, 10, 12.5, and here we give two groups, people who reach 10 milligram or they can increase to 15 milligram. Then open label, this is the blinding starts. So one group continue this and one group gets a placebo. So till this 36 weeks, your escalation stage, everybody received active molecule, tirzepatide. And after 36 weeks, till 88 weeks, one group, the same dose of Monjaro continuing, 10 milligram or 15 milligram, and the other group, injectable placebo. And I'll remind you, this is a double blind, means the device exactly will look the same in the both the group. Neither the subject nor the investigator will know what they are getting. And this is what you get. As expected, we know from surmount 1, when active molecule is given, it lost weight. Here in this one, 20.9%, same 21, 22% weight loss. Now in the red one, they continued the same dose of Manjaro. You'll remember it is 10 milligram or 15 milligram. And in the black one, they are on the matching placebo. But they are continuing with a reduced calorie diet and physical activity. As you see that when they reach 88 weeks, a good amount of weight regain has happened. They didn't come to the baseline, agreed, but good amount of weight regain happened. And this is what a good scientific recommendation, the importance of the continuation of the medicine. Proportion of the participant achieving the weight reduction threshold is basically same. Now you can concentrate on this one. We are talking about more than 25% now. 5%, 10% looks like in the surmount trial is nothing. So more than 1 in 2. So 56% has 25% weight loss. That's wonderful. Then again, change in the waist circumference, same thing we accept that up to 36 weeks, again good weight loss, and continue to good loss a bit more, whoever continued. But when you stopped, again some of the waist circumference increases as expected. And this is again re-emphasizing the importance of continuation of the treatment. Now what dose will continue when it comes tomorrow, that we can discuss in the discussion time. Adverse effect in the open level one, the first one, adverse effects are more or less the same, whatever we found in surmount 1, nothing much to tell. And with the double blind therapy, when the placebo group and the Manjaro group, as you see, there is not much differences there. Some people discontinued, and both surmount 1 and surmount 2, I think total around 4 people died. All of them, actually, death was related to the corona event. And it's wonderful to see that in that corona epidemic or pandemic, nicely the study is actually completed. It's a hats off to the investigators all over the world. Surmount 4, a similar thing. If you consider the percentage, so 15 milligram, initially the nausea and the diarrhea percentage are quite big, but they all tolerated. But we need to remember that most common adverse event is gastrointestinal. It will require a good counseling when you and me start using in our clinical practice. So in summary, surmount 4, that's again same indication exclusion criteria. 36 weeks lead-in open level, followed by comparing with the placebo. After 88 weeks, Manjaro maximum tolerated dose, which is 10 or 15 milligram, average body weight reduction of 26%, and 90% of the participants who continued on tirzepatide achieved the weight maintenance endpoint. From randomization, participants switched to placebo, experienced weight regain. So here 26%, here regaining 15%, that's what we are talking, and also regaining of the waist circumference. And a similar percentage of the participant in the Manjaro and the placebo reported serious adverse effect, and one death in each group in surmount 4 happened, and this actually, as I told, is a corona event. So personalized dosing for patients like Lena, again, I think it will be nice if we discuss this. So all of us will try to follow this as we have done for the dulaglutide. We will not, there's no hurry. This is not an acute disorder. We will start at the 2.5 milligram per week for 4 weeks, then 5 milligram per week, then 7.5, 10, 12.5, 15. Nothing will happen if we reach this 5th or 6th month. And another point, if they discontinued for some reason or other, better, suppose they discontinue the 10 milligram, probably we'll go back from the beginning of the 2.5 milligram only. I'm going to stop here, and we'll discuss the questions later. Thank you very much for your